very much. Very much.
All right. So, I would first like to wish everybody a happy Ganesh Chaturthi from Mumbai. It's a very, very big festival that is celebrated here. So, without much ado, because we've had some initial technical glitches, I would like to proceed with my talk on biomarker-driven strategies in the management of NSCLC and overview. As we know, lung cancer about more than 2 million cases and almost 1.8 million deaths per year are caused due to lung cancer. A very important thing which I would like to share with everyone is that lung cancer has almost stood out as a prototype of targeted treatments and biomarker driven management, in which we have moved from an era where we had a one size fits all approach of broad spectrum chemotherapeutic agents to agents which specifically target tumors which have particular specific underlying mutations. So these targeted therapies are directed against oncogenic driver mutations, which are unique to the cancer cells, and hence they spare the normal cells. Another important thing is that most but not all lung cancers are associated with a well-known carcinogen, that is tobacco smoking. In cases of squamous cell carcinoma, it is usually associated with smoking high tar content additives, whereas in adenocarcinoma, it is usually low to moderate tar content additives. It's important to know this because we usually go for biomarker testing in those in which we suspect oncogenic driver mutations, which are usually non-smokers or less smokers and younger patients. So whenever we are looking at anything, it's very important to understand the classification. As we know, lung cancer is divided into non-small cell and small cell. Non-small cell is further divided into squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. The biomarker testing is most frequently prescribed for adenocarcinomas because they are the most well understood and they have potent targeted treatments available. In cases of squamous cell carcinomas, these are still early days, and mainly we look at these cases. Why is it important to note what is the histology? Is because most of your biomarker testing will depend upon the type of histology that we have. As I told you, adenocarcinomas are the ones which are most frequently prescribed for biomarker testing. Whenever we get a CT guided lung biopsy, what we usually do is that we divide it upfront into two blocks, so that one block can proceed with histopathology and IHC evaluation, and the other block can undergo the molecular testing. So, adenocarcinoma is divided into different morphological types. That is lipidic, acinar, papillary, micropapillary, and solid adenocarcinomas. Squamous cell carcinomas are also divided into different types, which are keratinizing squamous, non-keratinizing, which is low grade. Acinar and papillary are intermediate grade, and carcinomas are the ones with poorer prognosis. Here you can see the keratinoid basaloid when the basaloid component is at least 50%. So with that, I would just like to proceed with the biomarker. In large cell neuroendocrine carcinomas, we don't have a lot of biomarkers. First came about at the advent of 21st century as anti-TKIs were tested on lung cancer patients. These were geftinib and erlotinib. Crizotinib was initially developed as a MET inhibitor, and further research contributed to identification of a whole new range of druggable targets, particularly for adenocarcinomas. As I told you, squamous cell carcinomas, we usually see the immune, we test for PD-L1. And these patients show spectacular improvement, particularly in those who lack TKI sensitive mutations. Now, in adenocarcinomas, till even today, most of the adenocarcinomas, about 40% of the cases globally, we don't see known mutations. But the picture slightly changes in the ones in which we see mutations. Like in the Western population, the kind of mutation patterns are different. More often we see KRAS mutations, whereas in the Asian subcontinent, we usually see the EGFR mutations, which are most prevalent. Squamous cell carcinomas, we do see a lot of mutations, but they are not targetable as of now. So KRAS mutations are associated with smokers. EGFR, AL, CROS, and RET are usually seen in non-smokers. As I told you, in Asians, the percentage of EGFR mutations is high. If you are getting an EGFR mutation in a squamous cell carcinoma, the first thing you should consider is a histological misdiagnosis, or these would probably have elements of a mixed histology and the adeno component has been missed. The two major EGFR mutations we see are in-frame deletions of exon 19 and the L858 substitutions in exon 21, which are usually seen in the elderly. There are other, rarer mutations like exon 18 nucleotide alterations, 19 in-frame insertions, 20 alterations, and 21 mutations. ALK and ROS1 translocations occur in about 5 to 8% and 1 to 2% of non-squamous NSCLCs respectively. Women and non-smokers, like EGFR, no racial differences. These are usually seen in younger patients. In contrast to the EGFR, there is a significant diversity of secondary mutations in ALK and ROS1. The probability of a particular TKI resistant substitution may depend upon the type of translocation. For ALK testing, IHC is a cause, positive cases must be validated by an alternative assay like FISH. Coming to BRAF, BRAF is the easiest to test as all druggable mutations fall on the same hotspot region. BRAF V600E, that exon 15, this is seen in 1 to 2% of adenocarcinomas. As single agent usually results in rapid resistance through MEK pathway. Therefore, a combined approach is usually instituted. Exon 11 mutations are detected rarely, but these are non-druggable. Then coming to the MET exon 14 skipping mutations, this results in overexpression of this receptor. This is seen in about 2 to 3% of non-squamous NSCLCs. And these are usually the elderly population who do not tolerate cytotoxic therapy well. Thus, if you are seeing a patient over 70 years of age, you should prioritize MET over ALK, ROS, and RET. The drugs used are crizotinib, capmatinib, and teptotinib. Then the RET mutation seen in about 1 to 2 NSCLCs. One of the newer kids on the block is the NTRK gene fusions, which were identified first in 2013. And so there are three NTRKs, that is NTRK 1, 2, and 3. These are seen in about 0.2% of non-squamous, non-small cell lung cancers. The drugs that are used for these mutations are entrectinib and larotrectinib. There are a variety of options to be able to test NTRK. I mean, there is IHC, RNA, DNA, NGS, FISH, and RT-PCR. There are advantages and disadvantages with each of the modalities. While RNA NGS is the most sensitive, IHC will always offer us cheaper prices and faster TAT. But the cases, IHC is a very good screening modality. So what is negative, you don't need to test further. But whatever comes positive on IHC, you should definitely validate it with a higher modality like RNA NGS. So many times, people ask me, which is the platform that we should use whenever we are going for these molecular targets. So see, if your sample has high volume, any method will work. But if your sample has low volume, you need amplification of the genetic material. So something like an ARMS would be the best modality. Whenever you have a mutation type which is known, like let's say EGFR, you can use a targeted method like PCR. But when your mutation type is unknown, then broad spectrum next generation sequencing is the studies that have been done. And for KRAS G12C, FDA approved the first targeted therapy, and these are patients with non-small cell lung cancer whose tumor have the KRAS G12C mutation and who have received at least one prior systemic therapy. The drug which FDA approved was sotorasib. Also, studies are coming forward for pyrotinib and HER2 mutant advanced lung adenocarcinoma. Then coming to PDL1 mutations in lung cancers, there are different clones for PDL1. There is the HP142, SP263, and DACO22C3. The clone we most often test is the DACO22C3 clone. And what we should usually do is, these are companion diagnostics. You should use the DACO clone on the DACO platform, and then these patients should be considered for pembrolizumab therapy. So the FDA approved, what we usually give is the TPS score in cases of lung, because inflammatory cells in lung are very few. So TPS correlates very well with CPS, and they saw that when you correlate with TPS, the understanding of the tumor was better. These are just the different types of staining that we see. What we should look for is a nice membranous staining. We should definitely avoid, when we are counting TPS, we should not count the inflammatory cells. Also, we should be careful of areas with necrosis, because these usually stain positive for
My apologies, sir. You are left with just 1 minute to conclude your presentation.
Sure. So I don't have much remaining. I would just like to show in a nutshell, this chart, which beautifully shows what all mutations, what all biomarkers we can test, and what are the drugs available. EGFR mutations have osimertinib, erlotinib, afatinib, geftinib. Then we have the ALK positive cases wherein the ALK inhibitors are used. ROS1 and ALK show homology, so they use crizotinib, entrectinib. For BRAF, we use dabrafenib, entrectinib, and for EGFR T790M mutations, which are usually seen in relapse cases, we go for osimertinib. This is again the same chart. In SRL, we have a NSCLC panel which covers both DNA and RNA variations in all these genes. I would just like to quickly embark upon liquid biopsy. These are important and these are very, very handy, especially in late recurrent cases, because they capture tumor heterogeneity. Even few copies of mutant ctDNA are sufficient for analysis. These are non-invasive and less expensive. And these are very compliant, because in cases who have been treated, you might not get a repeat biopsy might not be very compliant from patient compliance perspective. So liquid biopsies can be used. At SRL, we have a SRL liquid biopsy EGFR true test, which targets 42 mutations in 4 exons, 18, 19, 20, and 21. These are the test details. But we must know, I would just like to conclude with limitations of ctDNA. We must know that these are not very, very handy in early stage of disease, because patients might not have sufficient ctDNA. Also, presence of normal genomic DNA hinders with early stage disease and early detection. The sensitivity of ctDNA, detections of mutations at these ultra sensitive levels require a very, a lot of detailed cross across platforms and across laboratories. I would just like to finally conclude by saying that in India, we still have 2 spectrums. Most commonly, we get testing prescriptions for EGFR, ALK, and ROS1 because of cost implications. The others are just testing all the targets at one go. One point of caution would be that wait for your NGS reports before you institute your PDL1 treatment, because NGS report will take time, but PDL1 report might be available to you for 2 days. So with that, I conclude my talk.
Thank you, sir. Thank you so much. Thank you for the wonderful presentation.
This is my team at SRL Bombay, and I thank the organizers for giving me this opportunity.
May I ask one question to Dr. Kunal? Sir, I want to know whether the all MAT exon 14 mutation are skipping mutation or not. Means how to look at that, because only skipping mutation are targetable, not other. So
yeah,
how
so
to
all the mutations are not skipping mutations. So there are very specific patterns that we evaluate for the skipping mutations. And as you rightly said, that only the skipping mutation should be considered. The other mutations, we see a lot of other variances and varieties of mutations which are there, but those should not be considered for considering a MET, for targeted treatment.
So you mentioned in your report that it is skipping mutation or not?
Yeah, so we analyze only for the skipping mutation. Even our NSCLC panel, we analyze only for the skipping mutations.
Thank you, sir. Thank you, sir. Thank you so much for your for enriching us with the biomarker-driven strategies.
My pleasure. Thank you so much.
And next we move on